Good evening, everyone, and a warm welcome to today's webinar organized by ORDI. I'm Dr. Sarath, a clinical geneticist. I recently completed my DM from AIMS, and I'm currently working as a visiting consultant at Apollo Hospitals. Today, we are focusing on a complex yet fascinating group of conditions, that is skeletal dysplasia. The 2023 revision of nosology, if I'm not wrong, it includes almost 771 conditions. That's how complex this entity is. And as clinicians, we know that skeletal dysplasia present a wide diagnostic spectrum. Some can be spotters, just like achondroplasia, but many can be incredibly subtle and rare, where the phenotype is overlapping and difficult to pin down. And we have to rely on techniques like NGS. And we are eager to hear about these evolving diagnostic strategies today. So it's my privilege to introduce our guest speaker, Dr. Inusha Panigrahi. She truly needs no introduction, as she is very popular popular figure in both pediatrics and genetic circles. What is truly inspiring about ma'am's journey is that she has been trained and worked across the most prestigious medical institutions in India: IMS, BHU, SGPGI, AIMS, and PGI Chandigarh. For the past 16 years, she has been at PGI Chandigarh, where she serves as professor and unit head of Genetic and Metabolic Unit, Department of Pediatrics. She's involved in research on congenital deafness, Gaucher disease, primordial dwarfism, craniofacial disorders, overgrowth, and osteogenesis imperfecta. She has authored around 130 articles, and she is also a member of various scientific societies like SIAMG, ISHG, and ISIEM. Ma'am, we are incredibly eager to learn from your vast experience and the insights you have gathered over the years. Audience, please note, please post your doubts in the chat box. We will take questions at the end. Ma'am, the floor is yours.
Thank you, Dr. Sharath, for the kind introduction. So today we will be discussing skeletal dysplasias, genetic testing, and the new insights. So basically, I'll cover whatever skeletal dysplasias we see in the genetic clinic, what test we do, and then some work which we have done as part of the PhD thesis. So the skeletal dysplasias refer to abnormalities of the skeleton, which include the skull defects as in craniosynostosis syndromes, limb defects in different epiphyseal, metaphyseal, and diphyseal dysplasia, spinal defects in disorders causing kyphoscoliosis, and also diseases with dysostosis like MPS, spondylocostal dysostosis, they are also seen. And also those with clavicular thoracic predominant hip and pelvic girdle involvement, you can also see specific disorders. And skeletal dysplasia syndromes are also there, in which additional malformations are there. And the prognosis might depend on what type of skeletal disorder we are seeing. And there is no treatment for every disorder, but at least some disorders have some therapeutic strategies. So we'll cover some of this. So a medical institute in Karnataka state reported the prevalence of skeletal dysplasias among the newborns to be 19.6 per 10,000 live births, with fetal skeletal dysplasias being 5.2 per 10,000 births. So you can see in south, some areas there is consanguinity. So there may be a higher prevalence of some autosomal recessive disorders. But there are some disorders which are prevalent all over, like achondroplasia, osteogenesis imperfecta, though the genes may vary from region to region. So in this, we will discuss what is the nosology, some of the FGFR-related disorders, osteogenesis imperfecta, diagnosis and management, metaphyseal and epiphyseal dysplasias, through some case scenarios, and antenatal skeletal dysplasias. So nosology, as Sharath has pointed out, has 771 entries linked to 552 genes classified into 41 groups, indicating improvements in the molecular characterization of novel disorders. So now there is a tendency to talk with the gene involved, like DDR-related disorder, TRPV4 related disorder, or COL1A2 related disorder. So similarly, the FGFR3 chondrodysplasias, the type 2 collagen disorders, type 11 collagen disorders, sulfation disorders, dysplasias with multiple joint dislocations, filaments and related disorders, all these are covered, including skeletal dysplasia syndromes, all are covered in this nosology. So coming to FGFR-related disorders, one of the common cause of this FGFR-related disorder is achondroplasia. And also we see FGFR-related disorders in the form of Apert syndrome, in which you get craniosynostosis and syndactyly in the form of mitten hands. Sarath-R syndrome, in which you can also get intellectual disabilities and cardiac defect. And Apert syndrome is the most common of the craniosynostosis syndromes, present in 1 in 65,000 individuals, and has close relationship with point mutation of FGFR3. There are two common pathogenic mutations nearby in a particular region of the gene, and they cause most cases of Apert syndrome. And the estimated birth prevalence for Sarath-R syndrome, which is due to mutations in TWIST1 and FGFR2 genes, is 1 in 25,000, 1 in 5,000. So in Sarath-R you can get some deletion-related disorders, some mutation or variant-related disorder. So coming to some developmental aspects. So the sutures, you can see the suture mesenchymal stem cells are heterogeneous stem cell population, and the cranial bones are connected by fibrous joints known as these cranial sutures. And premature fusion of metopic suture before 3 to 9 months of age leads to abnormal heart shape or trigonocephaly. So similarly, sagittal suture fusion will lead to scaphocephaly. Coronal suture fusion can lead to anterior plagiocephaly. There can be unicoronal or bicoronal synostosis. Then lambdoid suture fusion will lead to posterior plagiocephaly, and brachycephaly with result when bilateral coronal sutures are or unilateral, some amount of brachycephaly will be there. So in Apert syndrome, you have acrocephaly, brachyspinocephalic type head shape, and in addition, synbrachydactyly of the hands and feet. There is fusion of the fingers, and so that is called mitten hands and feet. And you can see the pictures here. You can see just pointer. So here you can see how the fusion, complete fusion is there. Here you can see some of the fingers, and in the X-rays also you can find out the syndactyly is there, and the abnormal shape of the hands and feet also that can be found out, and accordingly the operative intervention is done to release these fingers so that it becomes utilizable. So to confirm this, you do Sanger sequencing because two common mutations are there, 758C2G and 755C2G. So these cause most of the cases of Apert syndrome. You can see the Sanger graphs or chromatograms. So in this, you can see heterozygous state, you will get two peaks. Here you can see FGFR 755C2G and FGFR2 758C2G. So here two peaks, that means heterozygous. And if any other mutation is there, then you might have to select different primers, and other mutations also you can find out because these genes are usually large genes. So in Sarath-R syndrome, this was a copy number variant we had identified on chromosome 7p21, 21.32p, 15.3 deletion, and there were 39 genes, including TWIST1. So this causes Sarath-R syndrome deletion type. So then achondroplasia, this is a common FGFR-related disorder. And in this, you can see this trident hand, large head, rhizomelic limb shortening, and one can detect the mutation even on Sanger sequencing also. There's again here two common mutations are there, C1138G2A and another at the same position. So these common mutations are seen in most of the patients. So you can see this is a glycine substitution. And so this is a this pathogenic variant can be easily identified by Sanger in most of the cases. So vosoritide is a type of therapy for this achondroplasia, but there is difficulty in getting this drug because it's costly. And so some support, patient support program or NPRD or some other corporate reimbursement should be there for this treatment. So similarly, there are other also treatment molecules available for other skeletal dysplasias. So another FGFR disorder is encephalocraniocutaneous lipomatosis, in which mosaic activating pathogenic variant in FGFR1 or KRAS are identified on molecular genetic testing. On the basis of clinical criteria, major criteria, and minor criteria, it is possible to diagnose these patients. And in this, actually, there will be some asymmetry you will find when it is there, and some somatic variants are there, because in this, if you test the blood, you will not get, but if you test the tissue, you will get the variant. So now coming to osteogenesis imperfecta. Osteogenesis imperfecta results from recurrent fractures of variable severity presenting from antenatal period to adulthood. And additional features include short stature, hearing loss, dentinogenesis imperfecta, scoliosis. Many of you might have seen at least one or two cases of OI. And now it is possible to do mutation testing and identify the cause of OI, though most of the mutations are in COL1A1 and COL1A2 genes. But in children, the other types of OI, autosomal recessive OI, are also predominant. So of all pathogenic variants, 40% are due to COL1A1, 30% due to COL1A2, 10% due to FKBP10, 5 to 10% from LEPRI1, WNT1, SERPINF1. So different type of studies from different countries, you will get this variability in the percentages of the mutations. So in dominant OI, you can see two patients in which COL1A1 variant was identified on next generation sequencing. In next generation sequencing, there is a massive parallel sequencing of different genes causing the disorders, common and rare disorders. And you can see here it is showing homozygous variant. Homozygous, I think it is written wrongly. It is autosomal dominant, most of the time autosomal dominant if in this COL1A1 and COL mutation. So you can see the variant C1012G2A, glycine to serine. This is the change. And here again, the other patient, you can see this is the C3825G2A variant causing a truncating mutation. So this is most of these collagen disorders causing OI are heterozygous variants causing to a dominant disorder, leading to dominant disorder. And sometimes family history might also be there, and you may have to need to do testing in the other family members or do extended testing. So in X-ray, you can get this multiple fractures in different parts of the body, and then there will be some healing, and sometimes deformed limbs will be there. And when we give zoledronate, then there is cumulative effect of zoledronate, and you can see this in the X-ray. This arrow has shown that when you give zoledronate, this type of changes can be seen in the X-ray. This dense band that is seen. So we give usually 3 to 4 monthly in the patients zoledronate infusions, and so most of the in the most of the patients, there will be reduction in the fracture frequency, and though the height short stature will still be there, and so for that different approach will be required. So we reported this WNT1 related osteoporosis, in which the child was affected with severe WNT1 related autosomal recessive OI, and the mother and father had WNT1 related osteoporosis with early presentation of osteoporosis at an earlier age, which was confirmed by DEXA scan. Are the slides visible?
No, ma'am.
Now you can see. Can you see the slides?
Yes, ma'am.
Okay. So the management includes fracture stabilization, bisphosphonates like zoledronate, pamidronate, risedronate, neridronate, alendronate. The risedronate and alendronate, ibandronate, they are oral bisphosphonates, but they are not as effective as the IV bisphosphonates like zoledronate and pamidronate. Some centers use pamidronate, some centers use zoledronate. Other agents which or drugs which have been tried are denosumab and recombinant PTH. And corrective surgeries have to be done for deformities, especially in older child. Intramedullary rod insertion might be required to enable better mobility of the child. Then management of dentinogenesis imperfecta is also required, and many of these patients will have hearing loss, and so the management has to be done by the ENT person. And then here you can see in the photo, there is ptosis in this child. This was the WNT1 related OI patient with some dysmorphism and ptosis. So the treatment modalities include reduction of fractures by using this bisphosphonates, avoidance of contact sports, correction of the deformities. To increase the height, growth hormone therapy can be given, but sometimes there is increase in the fracture rate when you start growth hormone therapy. So controlled use is indicated. To improve the hearing, hearing aids, cochlear implants, other ear surgeries may be required. To reduce kyphoscoliosis. You correct the nutritional deficiencies, calcium, vitamin D supplementation, appropriate posture, and use of corsets, especially during travel. Then for improving cardiorespiratory function, treatment of the infections, better ventilation strategies, and guarded chest physiotherapy is advised. So other therapies include teriparatide, that is the PTH, recombinant PTH, denosumab, romosozumab, that is a anti-sclerostin antibody. Then for prevention, mutation testing, counseling, prenatal diagnosis, and severe cases of OI. So one has to remember that bisphosphonates may not be useful in IFITM 5 related OI. So denosumab, individualized treatment is required. All patients do not require. So most of the patients will respond to the bisphosphonates. So you can see in children also we can give this drug, though this is less used. Sometimes it can be given in combination with the zoledronate or pamidronate. So coming to the metaphyseal dysplasias, like Smith type is due to COL10A1 related disorder. Cartilage hair hypoplasia we see sometimes in our clinic also, that is RMRP related. In RMRP, since it is a small gene, so usually we do Sanger sequencing to identify this patient. Sometimes in CHH, you may not get actually sparse hair, only the metaphyseal dysplasia might be there. So a high index of suspicion is required. And then you can also get metaphyseal dysplasia with short stature. These are the POP1 and NEPRO1 related POP1 and NEPRO related CHH-like disorders. And then you have Swakman-Diamond syndrome, which is metaphyseal dysplasia with pancreatic insufficiency and cyclic neutropenia. In this, we have some cases of this SBDS. And so nowadays, since we have whole exome sequencing, we can easily identify these disorders once we have a high index of suspicion. So there are other conditions also like MMP 13 related autosomal recessive disorder, metaphyseal dysplasia, then MMP 9 related disorder, metaphyseal anadysplasia. There are other metaphyseal dysplasias with Magdalene hypoplasia, RUNX2 related. Then in sometimes you can get intragenic duplications of exon 3 to 5 or 3 to 6. Then so there can be sometimes a little variable presentation in certain gene variants. So in this case, 1.5-year male presented with poor height gain, short limb, similarly affected father. You can see the pedigree. This is the affected child and this is the affected father. And you can see the X-ray showing this abnormal femoral heads. You can see irregularities. And this is also shape is abnormal of this iliac bone. So this is metaphyseal dysplasia, spar type. We had kept a possibility. So 1.5-year-old boy, clubfoot at birth, deformity at knee, short stature, treated as rickets multiple times, valgus deformity of both knees, he had short hands, flexion deformity at hips, and was moving around with his knees. You can see the picture. So in the X-ray, on X-ray, you can find out whether it is mesomelic or rhizomelic or acromelic. So you see the changes, metaphyseal changes, epiphyseal changes. So here you can see metaphyseal abnormality is there in this child. Here also you can see in this position. So, but it is not that severe on the X-ray. So here you see this is the pelvic X-ray, the abnormality. So you see here epiphysis and the humeral head, any abnormal shape of this. So here you can see ear-like, it is looking ear-like. So these are the abnormalities that are seen. You can see epiphysis. Here this is the spine, again X-ray. So in this we identified the COMP gene variant in exon 13, heterozygous, causing multiple epiphyseal dysplasia type 1. So this is an autosomal dominant disorder. Then coming to another case, the child presented with pain in lower limbs at 2 years age, difficulty in standing from squatting position for last 2 years. So here again the pedigree showing both affected, father and child. Father had a similar complaint at 18 years of age and had bilateral caries hip, received ATT because of this. On examination, you can see the growth is preserved. Hemoglobin and other parameters are okay, except vitamin D was low. So this can be there in many patients, additional vitamin D deficiency, which has to be treated. So you see the X-rays, X-ray pelvis, mild articular abnormalities, and in the bilateral hip joints are there. You can see this indentation inside, somewhat indentation is there, and this abnormality. So in X-ray hand, there was stippling of the distal ulnar epiphysis, ulnar side. That is irregular and stippling, or you can say fragmented or small. So in X-ray left arm, irregularity of left distal humeral epiphysis. Here also abnormality is there, and here also it is there. So joint space also you can see. So in all the joints you can see some abnormality has been noted. Spine was, however, relatively normal. So again, this is multiple epiphyseal dysplasia. Father had in the CT destruction of epiphyseal ends of femur, bilateral caries hip. So we have 10 years old male, difficulty in walking. For last 2 years, development was normal, vitamin D deficiency was there, and multiple epiphyseal abnormalities at the end of the bones were identified. So this mutation showed MATN3 variant. This is the variant in exon 2, C359C2T. This is the amino acid change. So it is a heterozygous variant causing multiple epiphyseal dysplasia type 5. So we had another publication in which MATN3, this variant was identified. I'll come to it later. So in a Pakistani family. So exon 2, I suppose, is a mutational hotspot in this Indian subcontinent. So this was a different variant, but this was also in exon 2. So the classification of the variants is on the basis of different ACMG guidelines, and you have a PM1, PM2, PP3, PP5, this type of computational criteria, and then accordingly the variant classification is done. So this multiple epiphyseal dysplasia due to MAT-N3 matrilineal gene causes early onset arthritis or arthropathy, and then multiple epiphyseal dysplasia, arthralgia, pain in the joints, then short femoral neck, short femoral proximal femoral epiphysis, regular epiphysis, then some striations you can get, submetaphyseal vertical striations you can get, and delayed carpal ossification, tarsal ossification can also be identified. So coming to case 3, 8-year-old boy, unsteady gait, bilateral pain, lateral part of thighs, lumbar lordosis, restriction of the knee movements. There was also similar history in the mother. You can see from the back, both are standing. So here again, you see these abnormalities. And this some metaphyseal widening is also there. In this spine is also involved. You can see some osteopenia is there, and irregularity of this edges is there. So this is a some curvature you can see, and is in the hip there is joint space is much decreased. This was, I think, in the mother. So mutation testing was done, and we identified Pol2A1 variant in exon 23, C1510G2A, G2A, that's it will say glycine substitution, heterozygous, so causing multiple epiphyseal dysplasia or Steinescu type spondyloepiphyseal dysplasia. So usually in these collagen genes, glycine substitutions are important, and most of the time they will be deleterious. You can find in some of the skeletal dysplasias, and also sometimes in the spondyloepiphyseal dysplasia, and also in the osteogenesis imperfecta. If glycine substitutions are there, they are more likely to be deleterious. So coming to another case, cleft palate, severe failure to thrive, dysmorphism, cupped ear, microtia, joint laxity, sutural diastasis, narrow thorax. Mother had also short stature. So in this, you can see the child's X-ray. Here, clavicles are not there. So there can be hypoplastic or absent clavicles in cleidocranial dysostosis. And in addition, the child also had this microtia, some facial dysmorphism. So in this, child also had an additional variant. In addition to RUNX 2 variant, which causes cleidocranial dysostosis, heterozygous missense variant in exon 5. The child also had AFT UD2 variant. This is glycine to arginine substitution, leading to type of mandibulofacial dysostosis. So nowadays, since NGS is available, we can identify more than one disorder in a single patient or multiple disorders running in the family easily. So another case, 2-year-old girl presented with short stature, prominent forehead, narrow thorax, pectus carinatum, brachydactyly, brachymetacarpy. Initially, achondroplasia mutation testing was done because that was only available at that time. So at that was negative. You can see this narrow thorax. And we kept the DT as SCMD short limb hand type, asphyxiating thoracic dystrophy, SCMD type Maroteus, and TRPV4 pathy. So ultimately, you can see the X-rays here. Some calcification is there on the chest wall, and you can see the irregularity with some. Actually, there is all limbs are shortened. Some mesomelia is also there. Some bowing is also there, and you can see acromilic shortening is also there with irregular carpal epiphysis. So she had recurrent left-sided collapse of the lung and was tracheostomized, given oxygen support, ambroxol and saline nebulization. Actually, she had severe short stature, micromelia, and was put on tracheostomy and home oxygen therapy for 14 years. And the mutation done in this child from outside showed DDR2 variant. This is the variant C2107T2C, homozygous, so pathogenic variant, class 4, disease causing. So this was published in this paper, multi-gene panel sequencing in highly consanguineous families and patients with congenital form of skeletal dysplasias. This paper included patients from the Pakistan families, consanguineous families, and some skeletal dysplasias from the Indian subcontinent. So coming to another case, 3-year-old girl born of consanguineous marriage, low birth weight, presented with complaints of developmental delay, limping, difficulty in vision, myotonia, facial dysmorphism, short stature, microcephaly, and sad appearance. And CPK was increased. EMG showed myotonic discharges. You can see this some pursing of the lips. And we kept a diagnosis of Schwarz-Jampel syndrome. So in this, you get short stature, mask-like face, sad face, epicanthic folds, blepharospasm, telecanthus, pursed lips, short neck, muscle hypertrophy, myotonic proximal and facial muscles, and then skeletal muscles become stiff even in sleep. So we identified HSPG2 variant in this child, C1173C2A, exon 86, homozygous variant, causing Schwarz-Jampel syndrome. This is a likely pathogenic variant. So when we are seeing a case of suspected skeletal dysplasia, various factors should be kept in mind, like the age of presentation, whether the short stature is proportionate or disproportionate short stature, whether the height is preserved, whether there is pain in the limbs or the joints, whether there is bowing or there are recurrent fractures. So all these constellation of findings, they give a clue to the diagnosis along with the X-rays. X-rays which show whether it is rhizomelic, mesomelic, acromelic, metaphyseal, epiphyseal, diphyseal, or there are specific clavicular abnormalities or specific skull findings. Then additional biochemical studies or hemogram or DEXA scan can be done. Like in case of osteogenesis imperfecta, DEXA scan will show clear-cut osteopenia. And then definitive we look for other malformations like clubfoot, cardiac defect, polydactyly, hypogonadism. Then you can search on the database like OMIM, and then definitive testing will give a confirmation of the diagnosis. Sometimes if it is a clear-cut diagnosis, then and known mutation is there, one can go for Sanger. Otherwise, you have to go for NGS for multiple genes. And then sometimes after that also, if there is a VUS, you need to do some other test or additional family member testing. So pre-test and post-test counseling is important. Sometimes sibling or parental testing is required. The management options are discussed. And if it is a severe disorder, then you can discuss also options for prenatal diagnosis, and then you can offer in the PND in the family. So MPS2 is also a common skeletal dysplasia, though it is a lysosomal storage disorder. So we see usually in our clinic, and some few of these patients are also on enzyme replacement therapy. Developmental delay in joint contractures were seen in 86% of the patients, short stature in 79%, recurrent respiratory tract infections were seen in the children, in highest in all the subgroups of the MPS, and one child was admitted with autoimmune hemolytic anemia, immune thrombocytopenia. So some of these patients are on enzyme replacement therapy through different avenues. So the characteristic feature in these some of the lysosomal storage disorders, specifically MPS, is this dysostosis multiplex. You can get typical beaking, anterior beaking of the vertebra, and you can get also deformed pelvis. You can see flattening, here also flattening and deformation of the ilia, and on the skull bones also you can find abnormalities. So here also again there is beaking. So this is platysmondyle with beaking. So this is called dysostosis multiplex, easily diagnosed on X-rays. So antenatal skeletal dysplasia, severe phenotypes present in the antenatal period. There are several lethal skeletal dysplasias which cause severe micromelia and hydrops fetalis or stillbirths. Commoner disorders detected common disorders include chondrodysplasia punctata, which present with chondral calcification, short-rib polydactyly syndromes, thanatophoric dysplasia. Other causes say of severe growth retardation like chromosomal syndrome should be kept in the differentials. Chromosomal are more commoner, so but they will be associated with growth retardation and clear-cut microcephaly if in ultrasound is done in the later part of gestation. And antenatal next generation sequencing can provide confirmed diagnosis in some of these cases. So when you have a fetal growth restriction, long restriction with the long bones and abdominal circumference corresponding to the gestational age. So in this case, you see for the specific findings in the hands, limbs, face, genitals, then check the head circumference. You see whether there is relative macrocephaly or relative normocephaly. Accordingly, the differentials will be different. When there is a relative macrocephaly, it can be Silver Russell syndrome, 3M syndrome. If it is a normocephaly, it can be floating harbor syndrome. So these are actually causes of primordial dwarfism. And then if there is a relative microcephaly, different chromosomal disorders will be there. And then different syndromes will be there, like Smith-Lemli-Opitz syndrome. And in Sekel also you can get microcephaly. And the other conditions include Fanconi anemia, Nijmegen-Breakage syndrome, Dubovich syndrome. So depending on what are the findings, additional findings, you can get a clue to the diagnosis. So the prevalence of this skeletal dysplasias is estimated to be 2.4 per 10,000 births. 23% were stillborn. There can be internal anomalies, cardiac anomalies in Ellis-Van syndrome, ambiguous genitalia in Campomelic dysplasia, gastrointestinal abnormalities in achondrogenesis type 1, and bowing in osteogenesis imperfecta and Campomelic dysplasia. So, you can have a simplified approach like this. So irregular skull shape is there. You can think of thanatophoric dysplasia, chondrodysplasia punctata. If you see macrocephaly is there, you think of thanatophoric achondroplasia, Charcot-Levin syndrome. And if normal size with some hypoechogenic or absent bones, then you can think of other disorders like as mentioned here. So in achondroplasia, usually the femur length, short femur length will be detected later in gestation. But in severe skeletal dysplasias, which are mostly autosomal recessive type, you can get the shortening early in gestation, maybe by 12 to 13 weeks of gestation. So coming to antenatal case, HSPG2 related dissegmental dysplasia, there were 3 abortions in the consultant or the woman with curved femurs, syndactyly short limbs. So micromelia type skeletal dysplasia was kept in mind, and then deformities, lumbar sacral vertebral type deformities were looked for on antenatal sonography. Genetic counseling was offered. So you can see flat nasal bridge, bored limbs, vertebral segmentation abnormalities in this fetus. You can see the shortening, significant shortening of the limbs as compared to the spine. So you can see this irregularity in this cervical region. So this was dissegmental dysplasia. Sanger sequencing confirmed this. There were 2 variants. So we did the Sanger sequencing to confirm the variants. Mother had the C12793 C2T variant and father had the entronic variant in heterozygous state. So the child was confirmed heterozygous for these 2 variants. So again, coming to another case, or limb short, small thorax. So this was the baby. You can see again significant micromelia, very short limbs, and so this distension and narrow thorax. So you can see here some telephone receiver like bones. So the mutation testing identified FGFR3 variant causing this thanatophoric dysplasia. This was the variant C1118A2G. So likely pathogenic variant. So at 22 weeks of gestation, rhizomelic shortening was identified and punctate calcification in sacrum and ankle. So keeping possibility of lethal skeletal dysplasia, pregnancy was terminated. So you can see the baby. Here limbs are not so much affected, but still there is shortening. So the typical feature is the chondral calcification or the epiphyseal stippling that you see on the X-rays. And you can see the clear-cut rhizomelia clinically also, and also in the X-ray. So the variant identified was PEX7 variant C679G2T. Though it was a variant of uncertain significance, but it was clearly fitting into the phenotype. Then in these cases, you can go for segregation in the parents. So antenatal OI, there were also other cases like CRTAP related OI antenatally detected. So this was one variant. This is a frame shift variant, homozygous in one fetus, and in another baby with prenatal fractures, large head, we identified this one deletion variant and a duplication variant, compound heterozygous state, so causing CRTAP related OI. So in this you can get postnatal, immediate prenatal fractures or immediate postnatal fractures. So our research focuses also on skeletal dysplasias. We have done on this craniosynostosis, especially Apert syndrome and brachydactyly, and in addition polysyndactyly. And in these patients, some anthropometric analysis, some molecular analysis, and some biomarker analysis and transcriptomics was done. And we identified ALPL as a marker for differentiating this brachydactyly with osteolysis from Apert syndrome. Though both these are there is causing in this skeletal abnormalities, both are causing, but we found that the ALPL is highly increased in Apert syndrome, and in brachydactyly with osteolysis, ALPL was decreased. So some antibodies were taken against the bone proteins, and some special bone stains were used, and we identified these abnormalities on cellular level, taking patients' PBMCs, peripheral blood cells cultured. Then on day 14, you can see that the ALPL is orange color and the P10 is green color. Using these antibodies, we found this is actually the representing the normal. You can see normal color that is seen, but we found that in the patients, this is further ALPL staining. This orange color is higher in the patients with Apert syndrome. So these were correlated with the transcriptomic data also, the trend of expression in real-time PCR on transcriptomic data, that is on the RNA sequencing. So thus one can validate when someone gets a VUS, one can validate the findings by doing some ex vivo studies, and then make a better molecular characterization in some unexplained skeletal dysplasia cases. So take-home messages: clinical radiological evaluation gives clues to the diagnosis. Mutation testing by Sanger can be done in selected cases when there is a hotspot region or a common mutation identified. NGS or whole exome sequencing can be done for variant identification in most of the rare skeletal dysplasias. And newer avenues of treatment are under exploration for various disorders, including vosoritide for achondroplasia, and some romosozumab for osteogenesis imperfecta. And genetic counseling and prenatal diagnosis is possible for fetal skeletal dysplasias or severe osteogenesis imperfecta. So thank you everyone for patient hearing.
Thank you so much, ma'am, for that incredibly insightful session. It was nice to see how you balance the spotters we see in the clinic and with the deep genomics dives. So we have few questions, ma'am. Can we ask that?
Okay. Yes.
Yes, ma'am. So one question, ma'am. A very common scenario we see is children with skeletal dysplasia being misdiagnosed and treated for nutritional rickets in peripheries. So,
Yes.
in your experience, what are the clinical or radiological red flags that should alert a pediatrician that they are looking at a genetic skeletal dysplasia rather than a nutritional rickets?
So if multiple family members or multiple siblings are affected, again, it can give a clue. Or if there is a death in the family due to such phenotype, early death, then it might indicate that it is not just nutritional, but something, some genetic underlying factor is there. So first, once we see that there is rickets, genu valgum is there, and some changes are there on the X-rays, then Usually one gives a trial of vitamin D, calcium, and then sees what is the improvement. Suppose there is no improvement, given on 2 or 3 courses of this vitamin D and calcium supplementation, then one should think of some genetic causing this rickets, like presentation, or like we have X-linked hypophosphatemic rickets patients also. Some metaphyseal dysplasia which can appear overtly like this acquired rickets. So this should be kept in mind. Sometimes one of the parent, like the mother or the father, may be short, and then again it can give a clue to the diagnosis. In that case, one can do X-rays in the parent or proper anthropometric evaluation in the parent, so that you can establish that yes, it is inherited from the mother or the father. Sometimes we also get antenatal cases with short femurs. So in that case, if you see that the mother is also having flat faces, and also mother is short 4 feet, so you will not expect that that it would be a severe type phenotype. So you can counsel like the baby is likely to be like the mother or the father, whoever is short, and unless there are additional malformations associated on the ultrasound or MRI. So in that case, so that way we evaluate in our clinic, and so we can differentiate with proper X-ray evaluation, doing X-rays of the hands, feet, pelvis, so different areas, so that a proper diagnosis is made. So that is called a skeletal survey.
Nicely summarized, ma'am. So another question from Aniket is, which cases in what are the cases in which growth hormone therapy helps?
Growth hormone therapy is best for growth hormone deficiency, that is inherited. If it is also a genetic growth hormone deficiency, then also it will help. That is 100%. But if there is some other condition like Russell-Silver syndrome with growth hormone deficiency, there also one can try growth hormone therapy. Then you have some condition like Turner syndrome. Turner syndrome, some of the patients may benefit from growth hormone therapy if given early. So nowadays we can start even at 1 to 2 years of age. So if diagnosed early, then if therapy is given, they can benefit. In achondroplasia, there is the role of growth hormone therapy is controversial. Some reports say that is beneficial, some reports say it is not beneficial. And in OI, as I told, growth hormone therapy may be given in addition to zoledronate, but controlled use with proper monitoring is essential.
Okay, ma'am. Another
But it
question
is a cheaper form of therapy.
Yes, ma'am. Yes, definitely. Ma'am, another question is uh, the benefit of vosoritide in achondroplasia and any personal experience of that.
Actually, vosoritide has been approved by the FDA and by the EMA, European Medical Agency. But we can use after even 2 years of age. So initially it was approved, I think, for 4 years or 5 years. 5 years of age initially it was approved. But here we are unable to start because this is not included in that list of diseases in NPRD. So we have around, I think, 68 diseases now in that NPRD list. And if that disease comes under in that list, then only they allow use of the drug. Now we have applied for including that disease and the drug in that list, so that we can use for the patient. So now we have not started, but we have some prospective patients of achondroplasia in which we can start this drug. And already it has been proven to be of benefit in some of the patients with this disorder.
Okay. Ma'am, another question is, so this is something that we usually see in the genetics OPDs a lot, because there will be an isolated finding of short femur, and as such, there won't be any other finding. So in that case, what will be the approach? Do we need to go for an extensive testing, or do we need to get another ultrasound from a better radiologist? What will be your approach if you're suspecting a skeletal dysplasia?
Sometimes we get unilateral shortening also. Unilateral shortening of femur.
Yeah.
Unilateral shortening, that but that if it's just unilateral shortening is there, it may be isolated finding. If bilateral femoral hypoplasia is there, sometimes femoral hypoplasia can be part of some syndrome also. So sometimes you can get in kyphomelic, but in that usually you'll get also bowing with that. But at what period of time that bowing appears prenatally, we are not sure.
Yes, ma'am.
But in kyphomelic, you can get a bowing kyphomelic dysplasia. And now we have gene identified for kyphomelic. Earlier, I think 2 years earlier, gene was not known. So, but now we have gene identified for kyphomelic dysplasia, and a proper level 2 ultrasound is required to see what other bones are involved. And you check the centiles, different centiles of the different bones, and which is more likely to be most affected and which is least affected. And otherwise, if isolated just bone shortening is identified after say 24 weeks of gestation, it may not be indicative of some serious disorder or a lethal skeletal dysplasia.
Yes, ma'am. Another question, where can we get this list of rare disorders? I think he is asking about rare disease policy. It's available in
This
the...
list actually in any COE, from any COE you can get a list from the cell, rare disease cell. That list of disorders. Earlier, it was a smaller list, but now that list has increased to 68, or maybe now it is more than 68 disorders, because we have also applied for inclusion of NF1 in that list. Some from gastro also, some other disorders they wanted to give therapy. So exact number now I cannot say, but at least it is 68. But from any COE, this list can be obtained.
Okay. I think...
In case of primary immunodeficiency, actually there it is written etc. So any type of immunodysregulation or immunodeficiency, they usually allow this the new drugs that targeted monoclonal antibodies. But in other disorders, since ETC is not written, like disease, genetic disorders causing short stature, so that way if it would have been written earlier, so maybe we could have included more number of patients. But since that it is not there in the actual NPRD policy, so for new disorder you have to first include that disorder, and then you can give that drug to that patient.
There are no further questions. So I'm winding up. So thanks a lot, ma'am. This was a very complicated topic because we know there are 771 entities, 552 genes associated with skeletal dysplasia. And probably the take-home messages you have already mentioned. I will just paraphrase it once again. Don't suspect nutrition rickets diagnosis is not the end. Sometimes it can be skeletal dysplasia. Also in antenatally also they can present, and we need to go for an extensive level 2 ultrasound and go for invasive testing as well. And there are treatable disorders as well, and we need to have a proper skeletal survey to get the diagnosis. And one thing that we do in the Central Institute is that there is a dedicated radiologist who will keep on looking at these disorders X-rays, so that person is quite acquainted with the X-rays of the skeletal dysplasia, so that we can quickly go there and show the X-rays and get the probable diagnosis of the disorders. So thank you, ma'am. Thank you, Nisha ma'am, once again. This was a wonderful session. Thank you, ma'am.
Thank you so much. Bye.
Thank you, ma'am.